Folks, for those of you listening on YouTube, and those of you joining live now, I've made a very gross error. I've started the session without the one and only press. I also hear somebody chatting. Hello. I'll mute them for their own safety. I've said many. I think I've shared this with you all. I was on a conference, a guest on a conference, and I uh, was accidentally unmuted. And the moment in time that they caught, which is now recorded forever, is me yelling at Nar for him being so bad. And so that's been etched on time. So I get a little PTSD whenever somebody's unmuted. Um, but welcome, welcome. I'm very, very excited for today's session for many, many reasons. The first of which actually is today's been a wonderful week for the CP Solvers Academy. We have two new members who have joined our team, and I would love for them to say a quick hello before we get going. The first who joined earlier this week was Noreen. I'll hand the mic to you to say hi. Tell us a little bit about yourself.
Hi everyone. I'm not sure if you can, is there a lot of background noise?
Oh,
you're good? Okay.
Crystal
All
clear.
right. All right. Hi everyone. I'm Naren. An easy way to remember my name is to say now we are in really fast. And I'm really excited to learn from today's session. Yeah.
Welcome, welcome.
Yeah.
Thank you for that, Noreen. You look like you're in a cool spot somewhere, which is
Yes.
awesome. I can tell though that Jerome is in the comfort of his home, I believe. Jerome just joined the team today. Jerome, I'll hand the mic to you to say hello.
Hey everybody, my name's Jerome, third year resident in South Carolina at MUSC. I'm happy to be a part of the academy and looking forward to the days ahead. So I'm excited for some learning today.
Amazing. Likewise, likewise. Well, I'll hand the mic now to the one and only VJ. I will tell you that VJ is full of wisdom and has taught us so much in the academy. But I just so deeply admire his dedication to what we do, and the fact that he's jumping in and scribing last minute here is deeply appreciated. So VJ, I'll hand the mic to you to hear your voice because I haven't heard it in a while, and just to give us an update on how life is treating you.
Hello everyone, this is Vijay. I'm one of the CP Solvers member. It has been great. I've been in the inpatient clinic. So a lot of interesting cases coming up for the VMR.
Amazing. Wow, look at that teaser. Incredible. Thank you so much, VJ. We're very, very excited for it. Excited to see you here. I do want to throw a big shout out to somebody who probably doesn't expect this coming their way, but whenever we have an intern who is actually an intern in real life who happens to join real life VMR, we got to give them a shout out. So hello, Shreyash. It's so nice to see you. Maybe you can give us a quick update too.
Hey, it's so nice to be back. I just got this weekend off because I was in the clinic. I also have many interesting cases which
I'm sure you do.
Yeah.
We've already heard one of Shreyas's amazing cases from intern year already this year, so I'm sure they're stacking up. It's so nice to see you, Shreyas, on it. I'm glad you have the weekend off. I know.
Yeah, I have a whole list to present. I'm just going to prepare them now.
Amazing. All right. Well, I'm sure we'll hear about them very, very soon. We all
Sure.
are very, very glad to see.
I was listening to yesterday's case, very similar to that.
Oh,
yeah.
Well, thank you for that. I have to remember yesterday's case in my mind next time I see you just to get a little sneak advantage.
Sure.
Amazing. Well, Gerardo is also back and is joining us to do teaching points, having just completed his 10th semester. Welcome back, Gerardo.
Thank you so much, Ravi. Yes, and yes, I just finished my 5th year here in Peru, and we have 7 years of training. So I'm very excited to be back. Yeah, it's been a couple of very busy weeks, but yeah, I'm just excited to be back and learn from today's case.
We're very, very excited to have you back. Welcome back, my friend. And I know we're discussing together on a Thursday in the near future, so excited for that as well. Last but not least, I think this has been in the air for a long, long time, and I'm very, very grateful to Andrew to finally make it happen and bring Matthew Ho onto the VMR and for us to connect. I know there are very few people in the orbit of clinical reasoning who I know so much about but have never met until this very moment, and Matthew is one of them. So Matthew, I'd love to pass the mic to you to say hello and just tell us a little bit about yourself and the incredible work you do.
Thanks, everyone. So hi, I'm Matt. I'm currently a second-year fellow in Hem-Onc at UPenn. I did medical school in Dublin, Ireland, did my residency over at the Mayo Clinic, and now, Penn for Hem-Onc. I'm originally from Singapore, And I have an interest in sort of developing clinical algorithms, to help clinical decision making. And I've been a huge fan of the CPS team for a very long time. I actually use a lot of the schemas that you guys create and all of the stuff that you share, for free on Twitter and Met Twitter. So I'm really appreciative for all the work that you have done. And this case, I think, really highlights kind of why what you guys are doing is so valuable. Because a lot of the approach that I had for this case actually came from tutorials from you guys and also from Andrew as well. So I'm looking forward to sharing this case with you guys. Yep.
Oh, Matthew, wow, you left so much on the table there. I feel like we could talk for an hour just about you and what you've done from Singapore to Ireland to Minnesota, which is incredible. What prompted you to go to medical school in Ireland?
Yeah, so the main reason was because so Singapore has great medical training, but one issue with Singapore is that if you train in Singapore, you have to stay in Singapore because they bond you for at least 5 years in the government service. And in Singapore, they tend to not like physicians who do research as well. They like to sort of pigeonhole physicians into either more research or more clinical track. It's hard to do both in Singapore.
I see.
So that was kind of the main reason why I wanted to go overseas to do to pursue medical training. And a fun fact is that people might not know, in the past, a lot of the attendings and consultants in Singapore used to train in Ireland before our medical school sort of, got more rigorous. So that was kind of the precedence for me to sort of explore Ireland in particular. Yep.
Wow, that's incredible. I barely knew how to tie my shoelaces when I was pursuing medical training, let alone have the nuanced approach to know I wanted to be both a clinician and a researcher, and to like finagle that line. That is quite shrewd of you from such a young age. That's incredible. What was your experience like in Ireland?
Ireland was great. So very different from the US system. So the first couple of years were mostly, preclinical, even in the wards as well. It was a fun time, but I will have to say that, you guys have a much more rigorous clinical training. For example, you function like a sub-intern on service a lot of times. In Ireland, you're more shadowing, you're more sort of, learning by diffusion rather than actually, making decisions for the patient. So that's one thing that I hope could have been improved in my medical training. But otherwise, the nice thing about Ireland is that we are not a very resource-rich country like the US, but we do have technologies as well. So a lot of times you have to use clinical decision making to before pursuing tests. For example, like if you wanted to get a brain MRI, you have to really make a strong case to the radiologist. This is the reason why, and it's not just about if I want the test, I get it the next day. It's not like that in Ireland, unfortunately. So that's the nice thing about Ireland. You rely a lot on the physical exam, the history. Much more so than just getting like shotgun tests in Ireland.
Yeah, no, we supersize things here for sure. There's no doubt about that. The extra happy meal with the super large fries and Coke also applies to healthcare for sure. Well, hey, I don't know if we're gonna see Prof. Reza. I'm not sure where he is, but hopefully he'll be here soon. If not, I think I need to supersize you all and lean a little bit more on you. So if he isn't able to make it, we'll do a couple of breakout rooms to benefit from your knowledge. But Matt, why don't we go ahead and get started with your first aliquot when Vijay is able to share the screen?
Yeah, so a 74-year-old Caucasian gentleman presented to his local emergency department with 1 day of sudden onset fatigue and a painless purpuric rash affecting bilateral legs, his forearms, the back of his hands. And he has a history of calreticulin mutated essential thrombocythemia, for which he's taking hydroxyurea 500 milligrams daily. He also has stable coronary artery disease on aspirin 81 and rosuvastatin 10, and a history of polymyalgia rheumatica on prednisone 10 as well. He tells the ED physicians that he had been in his usual state of health and was golfing 1 day before all of his symptoms started.
Oh my gosh, I'm so sad that Prof. Reza isn't here, because this is the first time we've had a patient golf during their unfortunate illness. Is this a good place to stop, Matt? Have you
Yep.
Yeah, okay, wonderful. Yeah, I think that before we analyze the foreground, it's probably helpful to enrich ourselves for a brief moment on the two really key pieces of medical history we've received. The first is we know that this patient has a history of essential thrombocythemia that is calreticulin positive and has a history of polymyalgia rheumatica. The history of polymyalgia rheumatica is much harder to prove than the history of essential thrombocythemia, as PMR is a seronegative pain syndrome characterized by discomfort in the shoulders, the neck, and the hip girdle. And so as we proceed through this case, I think the one thing that we have to remind ourselves, as Mark emphasized yesterday, you really have to question both the severity and the validity of all underlying medical conditions. And so yesterday, Mark reminded us that for every patient who has diabetes, he puts in his note the parentheses A1C. And so here, polymyalgia rheumatica parentheses, how was it diagnosed? How did it present? And how has it been doing? Because there really is no defining feature of this condition. From the get-go, anytime that anybody with PMR is not doing very well is one impetus to look to question the diagnosis, but an impetus also to wonder if they have the more sinister association of giant cell arteritis. Now, thankfully, we stand on a lot more firm ground with the history of essential thrombocythemia because we have an associated mutation positivity. But I will tell you, as a non-expert, I'm very excited to hear Matt's thoughts at the end. I've also seen and heard about patients who get JAK2 testing in inappropriate settings and have incidental JAK2 positivity that has no bearing on their actual clinical outcome. So this, even though it seems true that the patient with essential thrombocythemia has a much likelier case of a true diagnosis, it's not 100%. And the reason it's not 100% is because these mutations can be of unknown significance if not tested in the right clinical context. But fundamentally speaking, what is essential thrombocythemia? It's helpful to think of it under the class of myeloproliferative neoplasms. And one very simple way of thinking about all the myeloproliferative neoplasms is to draw the fishbone diagram of the CBC. And in the area of the white blood cells, we have the leukocyte predominant myeloproliferative neoplasm, which is CML, a BCR-ABL positive disease. In the section of the hemoglobin, you can put polycythemia vera, which in the vast majority of patients is a JAK2 positive disease. In the platelet section, you can put essential thrombocythemia. That is a disease which we'll talk about the most at the end. Instead of putting the MCV at the bottom of that fishbone, I remind myself of myelofibrosis, which is a disease that can actually begin as a primary disease or as a secondary complication of all three other diseases. Now, there's one thing unique about essential thrombocythemia is unlike the other disorders, it is a pure platelet disorder. So unlike patients with polycythemia vera who can have elevations in their white counts or platelets, or patients with primary myelofibrosis or patients with CML, the only main abnormality is essential thrombocythemia is a high platelet count, and on bone marrow biopsy only changes in the megakaryocyte line. So essentially, it's a pure platelet issue. It makes it very, very unique. And so that's the context in which we're in, and it's hard to ignore that context because the patient comes into a fairly unique syndrome. And that syndrome is sudden onset fatigue. How many patients have we heard about on VMR or taken care of in real life who present with sudden onset fatigue? Fatigue is usually a cumulative issue. And in fact, whenever you're taking care of a patient with fatigue, you want to make sure, I should say, that you're not making a mistake by skipping over one common linguistic issue with the word fatigue. And that linguistic issue can be that the patient really means that they have exertional fatigue. That unlike Shreyas, who is working very, very hard for 5 months in a row, who probably has low-grade constant fatigue at rest, this person might mean that he has fatigue when he exerts himself. So if you're suffering the exhaustion of intern year, you're fatigued all the time, and it doesn't matter if you're walking or not. And I'm already very interested to understand, is this the fatigue of intern year that can happen from substances, from medications, from metabolic issues? Or is this the fatigue that actually is exertional? And exertional fatigue maps on very well to a painless purpuric rash. Because a painless purpuric rash might mean a problem with blood vessels or platelets, which is a much more hemodynamic syndrome than anything else. So what would we want to know next? I think the first thing is we got to realize that we have to pay very, very close attention to what's happening because of the patient's background. And I'd love to understand from the patient whether he's having exertional fatigue or whether the patient has significant fatigue at rest as well. The next step for understanding his rash will be to examine it closely. And since we know it's purpuric, well, we know it's a blood vessel issue. And by examining it, we'll be able to figure out, is the problem intrinsically of the blood vessel wall, or is it a problem with the blood itself? The way we can distinguish that is if we can try to see if we can feel this purpuric rash, i.e. palpable purpura. If we can feel it, what we are feeling is engorgement of the vessel wall. If we can't feel it, then what that means is the vessel is now empty because it has lost its contents, i.e. blood, into the soft tissue. So before we analyze and try to make progress on these these two pieces of data, we want to understand them better. Is this exertional fatigue or fatigue at rest? Two very different worlds. Is this purpura with an empty blood vessel that is non-palpable because the blood has gone out of it, such as that can occur from thrombocytopenia? Or is this purpura with a thick, engorged, angry blood vessel like vasculitis? Vijay, just for a clarification for describing, I think the rash is a purpuric rash. Is that right, Matt?
Yep, that's right. Non-pruritic, purpuric. Yep.
Purpuric. Gotcha. I heard those magic words of purpura. I couldn't forget them. All right. Thank you so much, Matt. All right. Why don't we get unless there's any clarifications you want to make about any of the heme stuff I mentioned or anything really, we can go on and get the next aliquot.
No, that was spot on. I mean, you got so much out of a very short aliquot, so I'm thoroughly impressed as always. And if you don't mind, I would like to share my screen now to sort of show you how the rash looks, and then we can talk a bit more about the physical exam. Okay. Let's see. Just have to give permission. My own computer. Sorry about that. Ooh, I will need to quit and reopen because I need to give permission to Zoom. Is that all right? All right, can everyone see my screen?
Yes, yeah, it looks awesome.
Perfect. So yeah, so this was how the rash looks. So on physical exam, basically he had a non-blanchable, non-palpable purpuric rash that I thought was branching. And this involved his bilateral lower extremities, his forearms, the back of his hands, but also the tip of his nose and his right ear also looked purpuric as well. So I can go into kind of the labs if you would like me to, or...
Yeah, I mean, I'll just share my reflex thoughts on this, if you don't mind. I think that it's interesting to the extent of the rash is marked, and I think that it's really powerful to see how deep and extensive the rash is. And you mentioned that it was not palpable. Is that right? You could not really feel it. So the lack of it being palpable argues against vasculitis or a vascular wall problem. The fact that it's so extensive is fairly unique and fairly interesting because the lack of it being able to be felt suggests that the problem is actually with the blood leaking out rather than the blood vessel. The blood being the focus of our attention now allows us to dissect the components of the blood in a little bit more detail. And the two key components to analyze here are issues with platelets, which of course have to be on your mind simply because of the association of essential thrombocythemia with the word platelets. And we can talk a little bit about that because that may be a little counterintuitive. Because you may be saying, wait, essential thrombocythemia is a problem with high platelets. Why would that be relevant? Well, it can be relevant in two ways. The first is that if your platelets get so high, what happens is they consume your von Willebrand's factor. And you, as a result of extreme thrombocytosis, develop an acquired von Willebrand's deficiency. More ominous, though, is when your platelets become low in the context of essential thrombocythemia, which can mean one of two things. Either you've either deliberately or accidentally overdosed on your hydroxyurea, or your own clonal process has evolved to something more sinister, like secondary myelofibrosis or acute leukemia, usually myeloid. All those are on the schema, but you can try to associate their likelihood based on other features of this case, but let's not do that for the sake of time. And I'm not doing that because I'm worried that the problem here may not be related to platelets. And the reason I'm worried that is based on the extent of the bleeding. This is not petechiae. These are ecchymoses. And ecchymoses are much more consistent with a problem in the coagulation cascade. And what's interesting is that ecchymoses usually are dependent like this. And the fact that he also has some on his face is something that stumps me and I find very, very intriguing. But the reason I'm very worried acutely is I worry that the severe fatigue may represent a manifestation of just how much this person is bleeding. And I'm on the edge of my seat to try to find out what his hemodynamics are. Because I worry that if he's really that fatigued, his hemoglobin might be significantly impaired. And bleeding from the skin may be the least of his problems, a clue that he's bleeding deeper somewhere else. So if you weren't already very worried about this patient from hearing how aggressive this tempo is and how vulnerable his background is, the extent of his mucocutaneous bleeding is very, very serious. So to summarize, we're going down the blood problem because there's no palpability. And within the blood problem, platelets or coagulation factors. The extent of the bleeding here suggests a coagulation factor. But good news, folks, we don't have to think too hard. The initial screen of labs will allow us to become much more confident in these early hypotheses. All right, Matt, I'll hand the mic back to you.
Gotcha. So his vitals are as follows. So he was afebrile, 36.8 degrees Celsius temperature. Blood pressure was 146/85. Respiratory rate was 23. And I forgot to mention just now, it was more generalized fatigue rather than exertional fatigue. So we got a CBC on him. Hemoglobin was 11.1 grams per deciliter. The MCV was 101. Platelet count was 293,000 per microliter. White count was 3,500 per microliter. Complete metabolic panel was unremarkable. Everything was within normal limits. We also got a peripheral smear that showed 1 to 2 schistocytes per high-powered view, occasional elliptocytes, occasional dacryocytes or teardrops. There was rouleau formation, but no red cell agglutination. We also got basic hemolysis workup. Heptoglobin was 139 milligrams per deciliter, and that's within normal range. We got a prothrombin time, 16.3, normal as well. Oh, no, sorry, that was elevated. Prothrombin is elevated at 16.3. Fibrinogen was 262, which was normal. The D-dimer was elevated at 11.9. And we also did basic, bacterial and fungal blood cultures that were negative.
Wow, this is unbelievably interesting. Maybe I can just summarize for everybody and we'll go into a breakout room as Prof. Rez's meeting is going to be ending soon. He'll join us right after it. So it sounds like we have a touch of leukopenia, a touch of anemia, and relatively normal platelet counts with a high MCV. The smear is interesting because it has schistocytes and teardrop cells with rouleau formation. There is no evidence of a coagulopathy at all, and no evidence of hemolysis, though the D-dimer is very, very high. Is that a fair summary, Matt? Anything else I missed?
Yeah, that's right. Maybe a bit of kind of early DIC. I know the fibrinogen is normal, but his PT is slightly elevated. Dimer is high. might be a hint of kind of early DIC, but yeah, right, no overt coagulopathy. That's right.
Super helpful. Was the PTT? Oh, sorry, I missed that. Was the PTT also high or?
No, PTT was within normal limits. The PT was high. Yeah.
Gotcha. Okay. All right. That's very, very helpful. Thank you so much. Yeah, I think why don't we just go into a 5-minute breakout room session for all of you to talk through this very, very interesting case. And then when we come back, we'll kind of analyze the data. And Matt, feel free to go into one if you'd like, just to hang out and chat with people.
Funny, man.
He's up.
You're too funny, and I want to just apologize to everyone. I was the post-Thanksgiving coma is a real phenomenon, and you experience it. Usually Robbie texts me when I don't want to blame him, but he always texts me 5 minutes beforehand, and I didn't get that text today, so I am blaming him for showing up late. And I just want to say hi, Matt. How are you? I've been a huge fan of yours on Twitter. You put out the best frameworks and most comprehensive.
I appreciate the kind words. As I was saying, to the team before you stepped on, I've benefited so much from all the good work that you guys are doing. And this case is really testament to that as well. A lot of the approach that we sort of, used in this case was really from what, you guys were posting, what Andrew was posting as well. So, I mean, thanks for doing what you are doing and for free even. So, you guys are amazing.
Thank you, Matt. I will take a crack at it, but I'm going to obviously rely on my wiser, more full head of hair younger brother to add to it. Interestingly, when you examine the rash, you may first reflexively think, am I dealing with a skin condition? But that would be a mistake, because Matt was kind enough, and Robbie, to share with us that this is a purpuric rash. And when you're dealing with a purpuric rash, what your mind should translate that to is that red blood cells have left the blood vessel. They've extravasated. Now, one of the most important branch points in evaluating that pathophysiology of red cells leaving the blood vessel is whether the blood vessel is inflamed or not. But before you even get to that question of inflamed or not, there's another low-hanging fruit that you have to think about, and that is the clotting system. Like, how does blood clot? If I shave or if I have a cut, what are the essential ingredients? And the essential ingredients are platelets, both their number and their functioning, and then the clotting factors. And so it's so easy to make progress on a case of bleeding vessels. Let's just call it bleeding vessels. Let's not call it purpura, because that's what we're dealing with here. By first looking at the platelets and then the clotting factors. And the platelets we actually measure. We don't measure their functional capacity in the CBC, but here the platelet count is north of 200,000. And it is true that this patient has mutation-positive essential thrombocytosis, but those platelets are usually sticky, and many times these patients go on aspirin as a way to prevent strokes and other clotting processes. I know the patient's getting hydrea to probably calm down the bone marrow, but I don't think it has an effect on the functioning of the platelets. So I'm going to go out and say that the platelets are actually, with platelets at this degree, you shouldn't have a bleeding vessel or leaky vessel. With regard to the INR and the PTT, it's really important to measure both the PT and the PTT. It just doesn't seem abnormal enough to explain bleeding vessels. And you want to make sure to screen one more question. Is there any trauma? You might say, wait, Reza, how would trauma look like that? Well, in the form of compression stockings. Like someone may have trauma from the compression stocking and a vulnerability rendering them risky for a bleeding diaphysis. But bottom line is this: we have to end up in the pathway of vessel and what's going on at the level of the vessel. And so now you're going to look for signs of inflammation, both locally. How do you locally look for signs of inflammation? You just close your eyes and take your hand and put it across the rash. You can wear gloves as recommended. But if it's palpable, you've answered the question that you actually are dealing with inflamed vessels. If it's not palpable, you haven't ruled out inflammation, but all of a sudden, vasculopathy as opposed to vasculitis is what we are considering. So for this patient, I think that the interesting finding here, honestly, when you say vasculitis, it's either going to be immune complex mediated or non-immune complex mediated. And the non-immune complex mediated is really your ANCA-associated vasculitides, and those are all the small vessel because it's the leg, including MPA, GPA, EGPA. But you can't forget about immune complex mediated causes, from lupus to endocarditis to rheumatoid arthritis to drug-induced to hypersensitivity phenomenon. But if you step back and say, well, what about just vasculopathy without inflammation? There you're at stuff like amyloid and scurvy and senile purpura. But I want to say one thing here. The schistocytes are really fascinating. And like Robbie said, when you're trying to see if you're dealing with a microangiopathic hemolytic process, you need 3 findings. And these 3 findings clinch that diagnosis. A low platelet count, and I think we can say here this patient has a low platelet count from baseline. We just need to know what the prior value is. You need schistocytes, and we do have schistocytes. And then the third finding is you need a high LDH. So we would be sending an LDH, and we would for sure be looking for a microangiopathic hemolytic anemia process. And then that really, the prototypical examples include TTP, HUS, and DIC. But there are a whole host of other causes, from malignant hypertension to antiphospholipid syndrome to underlying malignancy. And what I'm trying to do right now, Robbie, to be honest with you, is like my mind first activated vasculopathy. I got concerned for vasculitis. I'll send an ESR or CRP, but then I saw the schistocytes, and all of a sudden I pivoted to more of a microangiopathic hemolytic anemia. So I don't know if there's something happening at the level of the vessels, causing them to be inflamed, causing them to leak blood vessels, and then causing them to cause in situ thrombosis, leading to shearing of red cells, leading to the schistocytes and the microangiopathic hemolytic process. As I'm going through that 2 overlap Venn diagrams of vasculitis and MAH, I was just curious, like, where does your mind go? Like, I don't think of like TTP HUS as causing petechiae unless you really have significant thrombocytopenia, But I'm just curious if we can maybe balance and dance a little together.
Yeah, Prof. Rez, I think that I'm not sure where to take that, because the schistocytes are prominent and there's a prominent vessel signal. And I think integrating the fact that this patient also has teardrop cells and has myeloproliferative neoplasm has me wondering whether the destruction of the formation of these schistocytes is actually occurring in the bone marrow. So whenever you see schistocytes, there's a problem in the environment of the red blood cells, and they're going through some traumatic experiences, and that traumatic experience can be what's called microangiopathic in the tiny blood vessels. It can also be macroangiopathic as the red blood cells course through the major blood vessels that either have a prosthetic valve in them or an intra-aortic balloon pump. Or it can actually be a chaotic environment through a very destructive problem in the bone marrow, a space-occupying process in the bone marrow. So I don't know how that links in with the bleeding diathesis the patient has. It's also intriguing that bleeding diathesis is occurring in very unusual place, like the tip of the nose. And so I think the leads to follow are you can't let the sun set on a microangiopathic hemolytic process once you've thought of it. And so I think the schistocytes are a very powerful clue. And merging them with leukopenia, anemia, and a thrombocytopenia, essentially a relative pancytopenia with teardrop cells, has me pretty worried about the bone marrow. And a bone marrow process that is acute, fulminantly acute like this, might represent a rapid transformation to acute leukemia in this patient. And whenever you have acute leukemia and even a hint of coagulopathy and bleeding, I think you are sitting on the possibility of a medical emergency like acute promyelocytic leukemia. So it's interesting that this case is pushing us to think simultaneously of TTP and of APML, and I never thought that would happen, but it's true, it's happening right now. So I think the only thing that I know is I would definitely want Matthew in real life and his team to look at this patient and see, hey, do we need to marrow this patient? And I think from outside the marrow, if the marrow is quiet and actually just the patient's baseline, which could be, then I think we're in an even more interesting space, because then we're likely, unless the patient evolves and gets sicker, because this could be a rapid onset infection that we haven't, if you tell me this patient has a dog like Nar sleeping over there is on prednisone, I'll tell you this is capnocytophagia on day 1. And on day 2 or day 3, he'll be very sick. Don't do that to me, Nar, okay? But if we sandwich this disease to just really prominent bleeding in the skin with normal marrow at baseline, no evolution, then this case becomes even more interesting, because there are very, very few diseases that do that. So I'm stuck, Prof. Reza. I'm still in problem-solving mode. I agree with you. You can't ignore the schistocytes. I'm just curious if the marrow is signal or is just baseline for this patient.
Yep. So all really, really good thoughts. So I'll just fill you in on the couple of labs that we were thinking about. So ESR was elevated at 59, CRP was elevated at 1.9. I went back and checked his baseline platelet count back in 2020. So about 3 years before presentation was 570, so slightly elevated. So this is a decrease from his baseline. He didn't have a recent bone marrow biopsy prior to this presentation, but we did marrow him, during this presentation, and it showed development of post-ET myelofibrosis with grade 2 reticulin formation. No evidence of elevated blasts otherwise. Again, we are seeing the megakaryocytic atypia that is characteristic of ET. A couple of other labs that were sort of asked for as well. He had basically a serology workup. Rheumatoid factor CCP were negative. ANCA was negative as well. What else? And basically, they also did a serum protein electrophoresis and immunofixation, and that showed a 0.1 gram per deciliter IgG kappa M spike. His kappa light chains were elevated at 28.3. Lambda light chains were within normal limits, so an elevated kappa to lambda ratio of 1.7. And dermatology also saw him, and they did a skin biopsy.
Awesome. Maybe, Prof. I'll just sort of analyze the hematological fingerprints and kind of reflect on the progress and pass the mic to incorporate the kind of the big picture maybe. And I think for me, I think what's happened is it's very, very interesting to say, hey, don't worry about the schistocytes, don't worry about the teardrop cells. And I think with this space occupying process of fibrosis in the marrow, taking up more and more space and creating a tumultuous environment, I think it's totally fair game to have your hypotheses of the schistocytes and the teardrop cells parked towards myelofibrosis as long as you demonstrate that the patient doesn't have an aggressive hemolytic process with a super high LDH, a super low haptoglobin. And I'm sorry I didn't mention this earlier, Prof. As Matt had told us that the hemolytic workup was completely negative. The haptoglobin is high, LDH is reassuring. So I think what we're doing here is a very tricky thing to do, is to become less and less concerned about the hematological dimension of this illness being in proportion to how rapidly it's developing. And when you learn and reflect on the tempo of essential thrombocytosis developing secondary myelofibrosis, it's slowly over time. And so I think it becomes more and more plausible that the hematological fingerprint, short of the SPEP, everything else except for the SPEP, is actually just happening in the background for this patient, and might be an incidental finding that is not directly causal to what's happening, though it may set the patient up to be immunocompromised, to be whatnot. But I think the tempo of the hematological fingerprint of the CBC is not proportional to the tempo of abrupt onset purpuric rash for 1 day. Now, that would have been different if Matt told us, hey, unfortunately, we found acute leukemia. That can happen very quickly, maybe not a day, but I wouldn't be surprised if we learned that it can happen over a day. So I think that's the progress we made on the heme. So I think we're getting closer and closer and closer to saying that this is a systemic disease with devastation in the skin and relative preservation of all the internal organs. And I think that's a very interesting space to be in. So, of course, I say that with caution because representing that problem means you're making a very rare problem representation. You're saying extensive coagulopathy, bleeding of the skin without systemic features. You should do so cautiously. But I think we're open to that possibility. And I'm curious what your analysis is, Prof. Rez, and maybe what you think of the paraprotein.
Yeah, you know, Robbie, I think in that previous aliquot, you suggesting the possibility of MPN transforming into AML or APML, leading to DIC and schistocyte, like it would be such a great unifying hypothesis. And I think that's really what Matt and the team were thinking until they did the bone marrow biopsy. And like, yeah, it's not a perfect test, but if there's blast like to the form of leukemia, I doubt you'll miss it. It's not like those Reed Sternberg cells that you're looking, you know, in a sea of normality or normalcy. So I think that now I love what you said, that maybe this schistocytes and tear is just the effect of a progress that's slowly scarring the marrow, being the essential thrombocytosis. So now we shift, we put that in the background, and we might say, hey, does this make the person vulnerable for another reason for vessel inflammation or not? Like we have to go through that hypothesis. But the focus now becomes the leaky vessels that are likely inflamed, based on the fact that the INR and the PTT and the platelet count can't explain this degree of purpura and ecchymosis, and also on the fact that there is signal to background inflammation. And as we mentioned, if it was palpable, then we would be done and say, we are dealing with a small vessel vasculitis, whether it's the tip of the nose or the legs. But because they weren't palpable, now we have to biopsy it. So before we dive down the path, I think maybe getting those biopsy results to confirm, are we dealing with a leukocytoclastic vasculitis, which is a fancy way of saying, hey, there's white blood cells that are invading the blood vessel and you're dealing with a small vessel vasculitis. Then we can incorporate what that paraprotein might mean or not mean. Does that sound okay, guys?
I just want to get one. I completely agree with that. And realistically speaking, that's exactly what you would be doing in real life. I just want to clarify that was this person golfing in frigid temperatures in Minnesota? Because I think that if that was true, then I would probably ask for a couple more things while we wait for the skin biopsy.
So this was around September in Philadelphia. So it wasn't very warm, but it wasn't necessarily super cold. Yeah.
Okay. All right. Sounds good. Whenever you're thinking about all these symptoms and you're worried about getting a skin biopsy, I think you can supplement your workup with a couple other things in the world of cold-related diseases. But I agree with Prof. Rez. I think the skin biopsy in this case will be very, very illuminating. All right, Matt. Mike to you, my friend.
All right. So the skin biopsy showed non-vasculitic occlusive thrombotic vasculopathy. And so they increased his aspirin from 81 to 325 milligrams. But his rash continued to progress very significantly during the hospitalization, now with worsening pain at rest, also a loss of left posterior tibial pulse, and he started to develop dry gangrene in his left greater than right lower extremity. So I can show you another picture. Let me just pull up the second picture, which is this. So if you can see, the second picture was how it sort of progressed to. So in the interim, IV heparin was started. They did lower extremity arterial Doppler ultrasound and CT angiography, and it showed a left distal popliteal artery occlusion that extended to the left posterior tibial artery. He did have a background of mild atherosclerotic disease. He underwent urgent catheter angiography and balloon angioplasty with 2 stents in the left popliteal artery. And post-procedure, they stopped his IV heparin. They put him on dual antiplatelet therapy, aspirin 325 and Plavix 75.
Is this a good stopping point, Matt?
It is, yeah.
What a case. Wow. First of all, those imaging findings were just striking. Thank you for sharing them with us. I think that, the biopsy is pretty good at determining if there's vessel inflammation or not. It is true that you might miss it here and there because we know this by like giant cell arteritis. Like sometimes we biopsy both sides because it could be patchy, the distribution of inflammation. But I think I really think you got to now think about non-inflammatory vasculopathy leading to significant ischemia and gangrene. Essentially what we're seeing here is gangrene. That's tissue that has died. And if you ask why is there gangrene, it's because of all the small in situ clots that are forming, which also explain why there is schistocytes. I think the schistocytes, this would be a very good explanation for them, that those red cells are shearing through the in situ thrombotic disorder. So the question becomes, why is this happening? And it's not because there's embolization, because you can see this is bilateral. It's more, I think, due to a hypercoagulable state. And the question becomes, what is driving this significant hypercoagulable state? And quite frankly, when you see such devastation, and by the way, this is beyond like the natural causes of atherosclerosis that may occur in someone who's aging or has hyperlipidemia. This is way out of proportion to that. When you enter that space of hypercoagulability, you really think of a few buckets. One of those buckets is there like an underlying malignancy that's yet to be diagnosed, leading to such, terrible ischemia and gangrene? An example of that is someone with metastatic prostate cancer, or just has a really bad malignancy, making them very hypercoagulable. There's really no evidence of that here. There's just that liquid cancer that has been progressing. So then the other category you think about is autoimmune disease. And in your autoimmune disease, the primary contender is antiphospholipid syndrome. That is probably the prototypical example of a clotting disorder. And with APLS, like in this patient, you would absolutely send the relevant studies. Now, it's a little complicated by the fact that the patient is on heparin, but you would send the beta-2-glycoprotein, the anticardiolipin, the lupus anticoagulant, and you may go look at the patient's PTT before the initiation of heparin to see if it was prolonged or not. So I think you have to think about antiphospholipid syndrome. And whenever you're thinking about that, you also have to think about lupus as another very hypercoagulable state in the rheumatologic world, but that would not be a good match with this patient's age, gender, and demographics. Infections have to be considered. This patient has myelofibrosis, and their white cells are low, and they're not functioning properly. And what infections, like if I just showed you this and said there was a fever, you would think about purpurifulminants of meningococcemia, and that can cause wreak such havoc. The thing that might make infection or acute infection less likely is just the other studies of the fibrinogen and D-dimer, and it just doesn't seem like it's that bad. But bacteria like meningococcemia can certainly cause this kind of devastation. So Rabih, what I'm really doing in my mind is I'm saying, why is this patient so hypercoagulable? And I'm thinking of just three big buckets: malignancy, autoimmune, and infection. And then there's no strong signal for malignancy. I think the APLS hypothesis is a good one. And then I think infection, there's no strong signal, but it's something to consider in someone who is, functionally immunocompromised. But I would love to hear what your thoughts are, my friend.
Rafael, I probably forgot to text you because I was getting a little nervous because I knew Matt was presenting today, and I knew I would feel this way at 10 o'clock Pacific, where I would just be completely blown away. And I'm just trying to imagine myself taking care of this patient. And I think what I would probably do realistically, Prof. Rez, is I would be like, I cannot miss APS. And then the rest I have to go and like go in a quiet place and just think, because like you, this is very, very hyper. I'm right in the same space. It's extremely hypercoagulable. necrosing off skin, but I'm left so perplexed by one thing. Why only the skin? Nothing else seems to be happening to this patient. Brain's fine, heart's fine, adrenals are fine, liver is fine. Kidney is, can you believe the kidney is fine in a vessel problem? Why only the skin? And I think that's the power of the weighted analysis of this case, the center of gravity, is his limbs are falling off. And if so, if we heard he was a smoker, we would think, oh my gosh, thromboangiitis obliterans. And so I'm really struck by how devastating this is to the skin. And it turns out that actually that's another clue to pull out antiphospholipid syndrome from the variety of things that can cause really bad thrombosis, is that it loves to necrose the skin. And what are, in the world of things that are all skin restricted, that's when Coumadin skin necrosis comes in. That's when, if you learn this patient used cocaine that was adulterated with levamisole, that might come in. But I'm really struck by one other thing too, Prof. Rez, is this happened to him overnight. You know, he was golfing, which I'll say to you and look you straight in the eye, Prof. Rez, he was golfing. And so that's where I think that you have to ask yourself, really, is this problem representation accurate? A hyperacute, skin restricted hypercoagulability syndrome. And this is the power of problem representation, right? Because if you can corner the disease by labeling the problem with as much precision as possible, then I think you cornered it. But the risk that we take by narrowing the problem representation to such a narrow view is that you might actually be missing a much more common problem. But if this truly is a hyperacute skin-restricted disease, I think the no misdiagnosis is antiphospholipid syndrome, but the family of the four C's are really on my mind. And the four C's are type 1 cryoglobulinemia associated with a paraprotein, cryofibrinogenemia, which is a related disorder of cryoglobulin, and then an entity, well, actually more before the rare entity, cold agglutinin disease, which we don't see because the patient's not having hemolysis. And then an entity I just learned about 2 weeks ago called crystaglobulinemia. And crystaglobulinemia is a fascinating entity that I came across when reading about monoclonal proteins based on Chiara's amazing case. And it really quite simply refers to the crystallization of monoclonal proteins in blood vessels, causing extensive skin disease and also often kidney disease. And what's interesting is a related entity that merges cryofibrinogenemia, cryoglobulinemia, and crystaglobulinemia. All of these things, by the way, are just proteins that crystallize abnormally in blood vessels. And the only distinction between all these fancy words is what the nature of the protein is and at what temperature it crystallizes. So there is an entity called cryocrystaglobulinemia, which is basically when your cryoglobulins have cryoprecipitating properties. I don't know this space with confidence to teach about it. I just have heard about it, and I think it is a good fit for an abrupt onset skin-restricted hypercoagulability. And so the family of four C's, cryofibrinogen, cryoglobulinemia type 1. Type 2 and 3 are not in real consideration because the RF and the complements are normal. Cold agglutinin disease, not in consideration because there's no hemolysis. And then crystaglobulinemia. Cryofibrinogenemia is very much in consideration, but the two conditions that are most associated with a paraprotein are cryo type 1 and crystaglobulinemia. And why is this an important chain of thinking? It's because you can go back, revisit the skin biopsy, and try to see and stain these proteins for their presence. And that's how you find them, in addition to, of course, running the appropriate samples thawed down to the lab to analyze them for these elements. So super rare problem. I've never really thought about it algorithmically and systematically, but very, very intrigued by trying to see what the final answer is and why this patient's developed this overnight and only their skin. I babbled so much, Prof. Rez. I'd love to tap into any thoughts that you have or whatnot before we learn from Matt.
Zero, man. That was awesome.
All right. So I think you guys really, I'm very impressed by how you're able to reason through everything. I think, a lot of the points that you guys hit on are very important to consider. So in terms of his APLS workup, antiphospholipid syndrome workup, it was negative. So his beta-2 glycoprotein was negative. The DRVV was negative as well. And they also did other hypercoagulable workup, like antithrombin, that was negative. He had no antithrombin deficiency, no factor V Leiden mutation, no prothrombin 20210 mutations. We sent his peripheral blood MPN testing. It came back positive for calreticulin exon 9 mutation. JAK2 V617F were negative. MIPR was negative. BCR-ABL was negative as well. And I think, someone asked about infection. So blood cultures were negative. They did a TTE, no evidence of any intracardiac clots as well that could be seen. So basically what happened next was, despite being on dual antiplatelet therapy and despite having had his angioplasty procedure done, his lower extremity gangrene continued to progress. And this would be the last aliquot before we review the diagnosis. I'm going to show you kind of the pictures of the progression. You quick second. Share. So it got bad enough that he needed a left BKA because his limb was not salvageable. So are there any other final thoughts or any other testing that you want done before we review the diagnosis?
I'm really curious to learn. I'm curious what Prof. Rez, what you have to say. I'm really in learning mode here, and rather than teaching mode, definitely not something I'm comfortable or I'm familiar with.
Yeah, really, I have no clue. And Matt, I can't wait to learn from you. Really, thank you for bringing these pictures. That's striking. I've never seen an extremity so dark. But yeah, please teach us, Matt.
Yeah, so one thing, when dermatology saw this patient, after doing the biopsy, they said that this is type 1 cryo until proven otherwise. And they were very confident. So we did send out serum cryoglobulin testing and it came back negative. And then we told them, this is negative. So what do you think? Them said, repeat it until it's positive. That was how confident they were that this is type 1 cryo. So, we did repeat it eventually. So we collected it between 2 heat packs to make sure that, we do not precipitate the cryos. We did everything properly. And it did show, positive cryos. Unfortunately, there was not enough material to do tithing on it. So we're not, definitively sure if it's type 1 versus type 2, but overall clinical picture, given that he has this lymphoproliferative disorder with the MGUS, we think it's more consistent with type 1 cryo. So basically, what we did next was we did, full myeloma staging, no evidence of any other myeloma CREP criteria. So this is what we call MGCS, monoclonal gammopathy of clinical significance. He was treated with plasma exchange. We replaced him with 5% albumin in preparation for his left BKA, because one of the concerns is that in a co-operating theater, you could worsen kind of the cryoprecipitation and it could worsen his gangrene. So we really wanted very quickly to get the disease under control, get all the cryos out of his body, and that was the reason why we decided to plex him. He was also treated with daratumumab, Velcade, Revlimid, and dexamethasone, which is first-line therapy, for myeloma. And he had his amputation and, following that, repeated his M protein studies, they were negative. Repeated his cryo testing, they were negative, and he did have a pretty good outcome and healing after the whole procedure.
Matt, my mind is blown. I'm curious to know, how did dermatology like reflex to cryo? And then was it a bit unexpected that the biopsy didn't show vasculitis? Because cryo, I associate damaging vessels through inflammation of the vessel, but I don't know what the sensitivity is on that skin biopsy.
Yeah, so good question. So basically, when we think about type 1 cryo, we don't really think about it causing vasculitis. Type 2 is the one that more causes vasculitis. So the way that type 1 cryos cause damage to tissues is more with vascular occlusion, vasculopathy rather than vasculitis. So the biopsy was quite fitting with more type 1 than type 2. And I suppose the main reason why derm really sort of hung their heads on this being cryo was really the pattern of involvement. So I think Mark sort of alluded to this earlier, and this was something that Andrew also shared in the tutorial as well. There was this amazing review article, approach to retiform purpura. So basically, whenever you see things like this kind of branching purpura, there is actually a term for it called retiform purpura. And the diagnosis are actually pretty limited. Not many things can cause retiform purpura. So you guys, sort of alluded to in this case, right? It's blood leaving the vessel. So there are really two big buckets that we can think about. One of them would be, anything that damages the vessels itself. So any vasculitis, for example, can cause retiform purpura, but also anything that causes occlusion within the vessel. And that review article very nicely sort of summarizes, as Andrew did as well. It could be clot, it could be abnormal protein deposition, like cryos, for example. The disease that was mentioned earlier, cryocrystalloglobulinemia. So that's a type of type 1 cryo. It's basically, a deposition of immunoglobulins, intact immunoglobulins that form crystal-like structures, but it is in the family of type 1 cryo. So it's kind of, pretty similar. So one thing that was very striking was that he did have, nasal tip involvement, ear involvement, kind of, dorsal hand involvement. And really a lot of the damage in his lower extremities were worse in the distal, more so than the proximal. I mean, it did eventually, get more proximal. But I think with the involvement of co-exposed areas, that was what really gave dermatology the confidence that, this, has to be a co-associated process, which you guys were alluding to earlier. And the only thing that really fit in his case was cryo.
I think this is such an incredible case and such a powerful way to really, I think what you said, Matt, earlier, the powerful way of just thinking through it. I'm so glad to hear that you and Andrew essentially like shared this space on Twitter and had this on your schemas. And I think ultimately, if you really answer the question, why is the skin disproportionately affected? And the answer really is because unlike everything else, the skin is not at body temperature. Everything else is. And so I think, yeah, it's devastating. And to think of that this can just happen overnight to somebody is really, really powerful. So Prof. Rez, I hope you stay in LA forever as you continue on your golf. By the way, if those of you who don't know it yet, Prof. Rez is going to be a professional golfer in about 2.5 years at this rate of growth. So yeah, I'm sorry. So sorry for babbling a lot and taking up a lot of your time. I know we're running late, but would love honestly to kind of tap you one more time, Matt, to see what big picture learning you took away from this case and what we can all learn from the really powerful presentation you brought to us.
Yeah, I think kind of, one thing that sort of, struck me on reflection is that, it is very important to develop approaches to various conditions that you see. And I think a lot of the good work that you guys are doing really helps, spread this kind of, this way of thinking. So number one is, develop new approaches to approach, various things. And, things like retiform purpura can seem very scary at first, but if you think about it, not many diseases causes retiform purpura, so that really narrows your differential pretty significantly. So you want to look for, things that can help you to narrow your differential, and I think the schema that was shared is pretty helpful. The other thing as well is that his cryo testing came back negative actually 2 or 3 times, and it's important to know that testing for cryos are super finicky. You really want to make sure that you warm the blood at body temperature, 37 degrees, and you transport it to the lab. And the lab has to know that when they spin down the blood, it has to be at 37 degrees as well, because you do not want the cryos to precipitate before you spin it down, because then you will lose all of the cryos. So it's very tricky to actually do proper cryoglobulin testing. and the other sort of thing that I learned as well is really this distinction between type 1 and type 2. Type 2 really causes more, vasculitis, more inflammation. Type 1 is more, things sort of, coming together very abnormally and causing, clots, causing basically ischemia. And one thing to sort of note as well is that he didn't really have a lot of clonal burden from an M-gas perspective. He had no M spike. And this is something to sort of take note as well, right? So basically, when you think about myeloma or M-gas progression to myeloma, that's a pure clonal burden, right? In order to develop myeloma, you need clonal burden. There needs to be enough plasma cells in the marrow. There needs to be, enough M protein to cause disease. However, some people have just very abnormal immunoglobulins, just because the paraprotein that is being secreted is just so abnormal. So even with very low and trace levels of disease, so if we look into his marrow, we didn't even see any clonal plasma cells. So it's really not the amount of abnormal immunoglobulins that matters in this case. It's just, how abnormal they are, and they tend to fold in very abnormal ways, and they tend to cause, a lot of weird diseases. Cryos are one of them, amyloidosis is another. There's a whole range of them. So that's just something to sort of keep in mind as well. And it's important when you're sending monoclonal testing, not just to do the SPEP. You really want the immunofixation as well. You want the kappa and lambda light chains as well. With the three together, you have about a 98% sensitivity at not missing monoclonal gammopathy. The 2% you miss is non-secretory gammopathy that you have to marrow them to find. But that's kind of one thing to sort of keep in mind as well.
Oh my gosh. I think the only shame about today is the fact that you're not here every Friday, which I think you should be. That was absolutely amazing. Thank you so much. This case will live on forever in VMR. Really, really appreciate your time, man. Gerardo, you have the unenviable task of the teaching points, but maybe for the sake of time, do you mind sharing your 2 or 3 favorite teaching points from the case today?
Yeah, absolutely. So, yeah, I think this was an amazing case, and the main takeaways from this case, I think it's the approach to a hypercoagulable state, and how you can establish a differential with this state only presenting to the skin, and the differential diagnosis that was presented with and we were discussing based on this were APLS and type 1 cryoglobulinemia, cryofibrinogenemia, cold agglutinin disease, and crystal globulinemia, which are things that we have to consider. And also, one important thing is that in cryoglobulinemia, there are 2 types, and type 2 is more associated with vasculitis, and type 1 more associated with ischemic problems. So those are my main takeaways. Yeah.
Oh, amazing. To be able to do that so concisely is awesome, Gerardo. I wonder if neurology you'll be a vascular neurologist as a result of your teaching in this case. That was awesome. All right. Well, thank you so much, Matt, for a really, really precious hour and change. Really, really enjoyed every minute of it. And big shout out to VJ for scribing, Gerardo for teaching points, Andrew for connecting us. And we really, really hope to see you back here on another RLR in the future. It would be a real treat.
Yeah, I actually have prepped another case as well that's pretty interesting as well. So
amazing. Hey, all right. I will get your email from Andrew, and we'll set you up for another time, okay?
Yeah, in this case, I think Mark knows this patient as well. So,
Ooh, intriguing. Okay, all right. All right, thanks, guys. See you later.